right, I think we'll get going here. Hello, everyone, and welcome to our workshop today with Adam Poulin, Program Administrator for Children with Special Health Needs with the Vermont Department of Health. Thank you for joining us for this Children's Personal Care Services workshop. All of our workshops, including previous ones, are recorded and can be watched on our VFN YouTube channel. The link is on our website, which is vermontfamilynetwork.org. Everyone who registered for today's workshop will receive a follow-up email with a link to this recording and a PDF of the presentation with live links. Vermont Family Network has been serving families of children with special health needs and disabilities and the professionals who serve them for more than 30 years. We are the federally designated Parent Training and Information Center, the Family to Family Health Information Center, and the Vermont chapter of both Family Voices and Parent to Parent USA. Today's workshop is being recorded, so please keep that in mind as you share information about your situation in the chat. These sessions will include live captions. If you want to turn them off, click on Live Transcript, then Hide Subtitle. If you are comfortable, you are welcome to turn on your camera. You can ask questions using the chat box, which you'll see at the bottom of your screen. Feel free to share information or links to resources that you found helpful in the chat as well. We know that we can learn a lot from each other. So I'm excited to introduce to you Adam Poulin. Thank you so much for joining us today. Take it away, Adam.
Great. Thank you so much. Let's see how smoothly I can screen share over here. Okay. And then get into all right. Well, thank you so much, Jamie, and thank you, Rachel, for helping to set everything up. And thank you just in general to Vermont Family Network for all the support you provide to children and families in our state. I feel really fortunate to have had a connection with VFN going back over 10 years now, and I look forward to keeping that connection going forward. So my name is Adam Poulin. I'm a program administrator for the Vermont Department of Health. Specifically, I work within the Children with Special Health Needs unit, and part of my role is to oversee children's personal care services. So we're gonna go through some PowerPoint slides today that are intended to provide a pretty high-level overview of children's personal care services. I tried to avoid technical language where possible, but I really, the hope is to help participants and anyone who views this down the road to really get a sense of the scope of the program, and also so that folks know how to get more information going forward as well. So I'm gonna move through my slides. So these are some of the topics that we'll touch upon today. We'll give a very brief, basic program overview. Then I'll focus a little bit more in depth in terms of eligibility. We'll go into the application process with a focus on, roles with this application process and what to expect in terms of the family's experience with the application. And then I'll give some information talking about the self-directed model that Children's Personal Care Services operates under. And then towards the end, I'll talk about some of the changes that Children's Personal Care Services has implemented over the last year during the public health emergency due to COVID-19. So as Jamie said, feel free to chime in with questions in the chat box. My hope is to wrap up these slides and leave plenty of time for questions and answers and further discussion, at least for 20 or 15 or 20 minutes towards the end of our time today. And again, I think we have a relatively small group right now. So if folks have questions or they want to put questions in the chat, if I'm talking too quickly or if I need to go back and you want to go into detail, please don't hesitate to put that in the chat. So we'll keep going here. Okay, in terms of a program overview, I'm going to use CPCS as the abbreviation for Children's Personal Care Services. So you'll see that a lot. So Children's Personal Care is a Vermont Medicaid benefit for clinically eligible individuals up to the age of 21. So a couple things to point out here. As a Vermont Medicaid benefit, we do require that Vermont Medicaid status is active, but we're not concerned with the particular aid category of Vermont Medicaid coverage. Personal care is intended to provide supplemental assistance to a child's primary caregiver in the form of one-on-one direct support to the identified child, to the eligible child. So you could kind of understand this to also imply that it's not intended as a wraparound service. It can be used in conjunction with other services and supports available within Vermont. But children's personal care is intended to connect families with funding that allows them to hire someone to provide one-on-one care to their eligible child. As I mentioned earlier, personal care operates in a self or family-directed model. So we'll talk about that in a few slides. But that's different from a service model organized around an agency providing the personal care attendant for a family. And then as a bit of a formality, personal care is administered by children with special health needs at the Vermont Department of Health on behalf of the Department of Vermont Health Access, otherwise known as DVHA, which is essentially the department and the Agency of Human Services that oversees Vermont's Medicaid program. We'll keep going. And just as Jamie, as a quick housekeeping, I had to close the chat window so that I could see my slides better. So if there's something, please feel free to interrupt me if there's a time-sensitive question in the chat. Thank you.
Will do.
Okay, so we'll move into eligibility. So the core eligibility categories for children's personal care services are called the activities of daily living. We refer to these as the ADLs. The ADLs are a pretty well-known set of nationally recognized domains related to essential self-care tasks. So they include bathing, grooming, toileting, dressing, eating. Mobility refers to a child's ability to move about their environment, and transfers refers to a child's ability to move from one surface to the next. If you were to Google elder care services in the state of Washington, you would eventually encounter the ADLs, just like if you were to look up children's personal care services in Arizona or Wisconsin. So again, these domains are very, very well established, and they're used to look at the level of support and individual needs with all the typical things they might go about during their day. So this little phrase here includes a link, and we'll make sure that the links embedded in this presentation are available to participants going forward. So children's personal care services is defined under Vermont Medicaid Rule 7406.3 specifically here. And this talks a bit about eligibility and says that a child qualifies for medically necessary personal care services based upon functional limitations in the age-appropriate ability to perform ADLs. So it's a bit of a mouthful, starts to get a bit more technical. We'll kind of dig into this a little bit further here. Just quickly though, Medicaid rules are where the scope, the intention, the eligibility criteria for a whole host of Medicaid supports and benefits are described and documented and memorialized. So the Vermont Medicaid Covered Services Manual is a rather dry read, but it's very informative. And some of the information that I'm pulling from or presenting on today is pulled directly from our Medicaid rule. Okay, so one piece, I'm gonna go right back really quickly, something that might have jumped out to you here. You know, we talked about the ADLs as the core eligibility categories and domains. We listed what those are. And then when we reference the Medicaid rule, we see this medically necessary piece mentioned here. And I think that's a very important piece to understand in kind of getting the general concepts around children's personal care services. And medical necessity starts to, it's a concept that's really used to describe all sorts of services and supports covered by Vermont Medicaid. So we'll get into this further here. The Vermont Medicaid covers services that are medically necessary. starts to maybe sound like insurance coverage language. But this means some very specific things when we apply it to children's personal care. Medical necessity is defined unto itself, though. There's a link here, and I pulled some of these definitions from the Medicaid Covered Services Manual, where medical necessity is defined. So services are medically necessary when they are appropriate to the beneficiary's health condition, when they help restore or maintain health, and when they're supported by documentation. This seems pretty straightforward so far. For children who are covered by Vermont Medicaid, medical necessity also means that there's been a case-by-case, a very individualized determination that a service is needed to support proper growth and development or prevent the onset or worsening of a health condition. So in addition to covering services that are appropriate to someone's health needs, help them maintain their health or get back to their health, for children up to the age of 21 covered by Vermont Medicaid, medical necessity requires a very individualized case-by-case decision around that specific child. And it includes this extra provision that a service might be needed to help prevent something from getting worse, or that might throw a child off their developmental progress. So I'm going to keep getting further into the weeds of medical necessity here. And I promise I'll bring it back to children's personal care services shortly. So determining the medical necessity of another health service might seem a bit more clear-cut than with children's personal care services. So examples that come to mind when I think about this, access to insulin for diabetes, or access to proper orthotics for a muscular or skeletal disorder. So in these cases, the medication or the medical equipment is pretty clearly directly connected to the nature of the health condition. Pretty clear to see how it's needed to maintain daily health, and how it's required to maintain proper growth and development. So with children's personal care services, when we talk about how medical necessity is applied to our eligibility criteria, we start to focus on age appropriateness. So for children's personal care services, medical necessity means that the child's need for help with their activities of daily living is so significant that their general health and overall developmental progress might be at risk if they weren't to get that extra help. So an important point to note here is that the amount and type of assistance that a child requires must be based upon age-appropriate expectations for the child's participation with their ADLs and their independence in different ADL domains. So one, I think, way to think about this is in terms of what do parents and caregivers typically do to support children of all needs, of all different developmental trajectories. We think that for infants and toddlers, it is generally expected that caregivers are providing almost total assistance. They're providing physical care. They're very involved in that child's ADLs. We wouldn't expect an infant or a toddler to really show independence with any of those ADL domains. As a child ages, so for school-age children or adolescents, we would expect caregivers to continue to provide some direct assistance, but gradually changing to maybe more verbal support and reminders. And then for teens and young adults, keeping in mind that children's personal care services can be authorized for individuals up to the age of 21 even, so certainly young adults, we would expect approaching total independence with the activities of daily living domains, potentially with occasional reminders. So when we say that personal care is a medically necessary service, that it's needed to help a child stay on their developmental trajectories, keep making progress, when we step back and keep in mind that personal care is authorized specific to those activities of daily living domains, we're saying that personal care services without personal care services, all that progress might be at risk. So In addition to the activities of daily living domains, we look at the instrumental activities of daily living domains as well. So many acronyms, kind of a mouthful. But these are a secondary set of domains that once a core ADL need has been identified, we take into consideration to really individualize the amount of hours per week that a child might be authorized for personal care services. So when we talk about the IADLs, these are the three domains we're talking about: communication, social competency, how does a child interact with their peers, and learning. And then for an applicant 18 years and up, our screening process looks at some other IADLs, such as money management or even meal preparation. So the ADLs are the core eligibility domains that we screen for and want to understand about a child's needs in order to authorize personal care services. Once we've identified a core activities of daily living deficit or impairment, or need for significant extra support, medically necessary support, then we take into account how does the child communicate with people around them? Are they understood by people around them? Do they have the ability to communicate their needs when they're uncomfortable? How do they do with peers in terms of social competency? How do they interact with siblings, with parents, with classmates? And then learning, how are they doing in their school environment? What does it take to help this child pick up new skills and learn more independence based upon whatever independence looks like for that individual child? So moving along here. The Children's Personal Care application materials and review process are used to make a case-by-case individualized determination of need by focusing on the extra support the child requires with their ADLs. And we make decisions based on an hours per week basis. Our screening process and application materials take into account multiple types of support that a child might receive, from direct physical assistance from a caregiver to adaptive techniques and goods and equipment, including potentially children who need step-by-step cueing, where they are physically capable of doing age-appropriate activities of daily living, but without a caregiver or a support provider there with them to walk them through each discrete step of an activity of daily living domain, they wouldn't be able to do it independently. So our process doesn't just look at when does a child need physical support with their ADLs. We can also take into consideration how cognitive differences and developmental needs intersect in the case of an individual child. So a child's diagnosis, while relevant to our process, and I'll talk about that a little bit, the child's diagnosis does not determine eligibility. So we have part of our application materials include verifying a child's diagnosis. And our Medicaid rule and the authority we have from Medicaid to authorize children's personal care services requires that we attribute the child's needs to some type of long-term health condition. So like a silly example to make the point would be to say, if a child had profound seasonal allergies, that might, we know that there's a diagnosis for seasonal allergies. But that type of diagnosis would not be looked at as long-term and chronic, and any impacts on that child's activities of daily living probably would not reach the threshold of medical necessity for children's personal care services. That's an extreme example to make a point. Otherwise, diagnosis does not drive our decisions. We look at a child's functional needs for support with their ADLs. So this kind of starts to double back on the fact that we have authority to make decisions around personal care needs on a case-by-case, individualized basis. And the application process, the materials we use, everything is very individualized to a specific child. We're not allowed to make arbitrary decisions and use arbitrary cutoffs. So children with certain diagnoses don't start off with a certain amount of hours per week, and children with another diagnosis, start at different hours per week. There's no algorithm. The clinicians that make these decisions, that I'll describe their process a little bit down the road here, they look at and they review every line of every document and every form that is submitted when determining eligibility. And then, as I've kind of said already, once a core ADL deficit is identified, we look at the child's social functioning, their learning needs, their ability to communicate. Those are the IADLs. And that information is used to further individualize the decision we make. So who determines eligibility? So we have a team of registered nurses who specialize in pediatrics, whose primary responsibility for children's personal care services is to determine whether or not it is medically necessary. And then if it is medically necessary, how many hours per week are needed to address that child's ADL specific needs. We maintain a contract with a PhD level psychologist who specializes in co-occurring developmental and mental health disorders. And our registered nurses consult with that individual whenever there's a question about the unique presentation that we see in an application, or whenever there's a question about how a child's developmental or cognitive or potentially mental health or even trauma-related conditions affect their ability to do their activities of daily living. We take a very multidisciplinary approach in this regard. We also consult with our clinical services director, who's an APRN, and our review team participates in inter-rater reliability exercises to promote consistency in the decisions we make across our reviewers and promote quality assurance. So we've talked a little bit about, or I've made reference to, our application materials and packet and process, but getting into the specifics about what is used to determine eligibility. We have a fairly comprehensive packet that is submitted and used for decisions. So we have an intake packet that captures a lot of information related to demographics, a service history, in terms of like what services and supports does a child have access to now, what have they had access to previously. It gives space to talk about other family circumstances, family needs, family strengths. We collect signatures from applicants, and when families give us permission, authorizations to communicate with other providers named potentially in the intake packet. And the intake packet captures a very high level view of families' needs, and it may assist in identifying some unmet needs for siblings or the family system in general, and it may lead to other referrals. In addition to the intake packet, we collect a care plan, pretty standard, I think, in that regard. And for new applicants, we do collect information related to diagnosis. We verify a child's diagnosis, but again, the specific ICD-10 code is not used to make a decision. The diagnosis verification form is available online. All of these materials are available online. We'll make sure there's a link where you can view them later on. And the diagnosis verification form is typically completed by a child's pediatrician, primary care physician. There's a list of folks with appropriate credentials who can verify the child's diagnosis. It does not have to be filled out by the clinician who determined the diagnosis in the first place. So in addition to these forms, we collect supplemental and supporting documentation. Some examples are IEPs for diagnostic evaluations, medical progress notes, discharge summaries, and treatment plans. And then we use a standardized screening tool called the Functional Ability Screening Tool, the FAST. And that is really the core part of our application packet. So we'll talk about the FAST here on the next slide. So we call this the FAST, and it was developed by the state of Wisconsin and approved by the Centers for Medicaid and Medicare, specifically for the purpose of determining needs related to the activities of daily living domains and the instrumental activities of daily living domains. It's a standardized tool used just for this purpose. The FAST is actually a set of different forms called different age cohorts. And the pre-printed responses on each different age cohort correspond to different age-appropriate expectations relative to a child's chronological age. So the FAST that we would use for a 4-year-old collects different information, asks different questions than the FAST we would use for a 14-year-old. The Vermont, there's a whole history. Potentially some of the folks participating today remember these transitions with the program. But the FAST has been in use now in Vermont going back to about 2013, when Vermont was going through a big redesign with children's personal care services, in addition to some other services and supports for children and families. There was a lot of work done to research a tool and incorporate a standardized tool into this process. And so Vermont adopted the tool that the state of Wisconsin developed, made very, very minor changes to it in order to preserve the integrity of the tool. And it's been in use since 2013. And although I've said the FAST is really the core component of our application materials, the FAST alone is not sufficient for us to make a decision about eligibility. We look at, again, the FAST is a standardized tool, but we look at a whole set of individual circumstances and needs for a child. So all those other materials I listed on the previous slide, the intake packet, the care plan, supplemental and supporting documentation especially, those things in addition to the FAST are what our clinicians review in order to make a decision about personal care eligibility. So I pulled a couple screenshots from the FAST so that you can take a look. You'll see here that this is the 4 to 6 year old age cohort in the ADL domain of bathing. And so the assessor who is responsible for filling this out, I'll talk about that role in a few slides, will work with a family to identify how the child's needs corresponds to these potential responses here. That's the 4 to 6 year old age cohort, and then another screenshot from the 12 to 14 year old age cohort in the eating domain. And it gives you some examples of what sorts of needs we're looking at and taking into consideration. So we'll shift gears a little bit out of eligibility in the application materials to the process for applying for children's personal care services. So a referral can come from multiple sources: medical providers, educators, case managers, other home and community-based service providers that a family might be connected to. But I think most often families self-refer. Now, the application materials, they are available to view online. We want to be really clear about all the materials that we use, but only a trained assessor can actually complete and submit the materials. So when we talk about a personal care assessor, we're referring to somebody who works at one of the regional designated agencies distributed around the state, who has gone through our training and is familiar with the application materials, the requirements for properly filling out the functional screening tool, and is connected with a designated agency as an employee there, so has a above average understanding of childhood development, is familiar with services and supports available in a given region, and is also in a good position at that point to help connect a family with other services and supports beyond children's personal care when they do the actual personal care application. So this is a link to the list of regional designated agencies around the state, along with contact information for those agencies. So the personal care assessor is responsible for compiling, completing, and submitting all the application components. Like I said, they're responsible for ensuring the FAST is completed appropriately, for assisting with the collection of supplemental and supporting documentation, and for meeting the child who's applying. There's some changes related to the observation of the child requirement due to COVID that I'll talk about in a few slides. In the assessor training presentation, where we go into more depth about the program and the application materials and really make some recommendations for best practice, we hope to really drive home the importance of detail in the application materials. So there's space for notes and comments throughout the application materials, both on the FAST, on the screening tool, and in the intake packet. And so keeping in mind that we really want to understand as much as we can about a child's needs, what it's like to care for a child across settings, we ask assessors to go into as much nitty-gritty, as much rich detail as possible. So truly our motto is more is more. And we would rather capture a whole bunch more information about a child than specifically their personal care needs. And on our end, in our review, we'll go through all the materials submitted. We'll follow up with an assessor when we have questions. We might follow up with a family when we have other questions. When we're authorized to do so, we might follow up with a provider named in the application if we have questions. And it's all towards the goal of making an individualized award that fits within the eligibility criteria for children's personal care, that we can defend on audit if need be. Maybe I could have started the presentation by saying that our goal is to connect children and families with services and supports that'll make a difference in their daily living. And so the more detail we have in the application, the better. So in terms of getting the ball rolling with an application, in terms of what to expect once a family requests a personal care application to be completed, connects with the regional designated agency for that purpose. The bulk of the application process is a parent interview. Parents and primary caregivers are the key source of information about their child's needs. Like I've said, we want there to be a lot of detail whenever possible provided to the assessor. The assessor's responsibility is to figure out where in the application packet information is most appropriate to document. And keeping in mind that we are collecting very personal and very private information about the child, it really may not be appropriate for the child applying, the adolescent, to be present for the entire parent interview, which might present some logistics questions or something to plan out ahead of time when you're scheduling the personal care application parent interview. Largely, the parent interview can be done over the phone, so that we hope that there are options where parents and caregivers feel like they can speak very openly, get into detail, and potentially not embarrass their child, or potentially underreport their child's needs. There is space in our application and across our application materials to talk about a child's strengths, the progress they're making and growing and developing. There's space to frame things in a positive way. Ultimately, we have authority to allocate personal care services for areas of significant need. So a lot of our application materials do use language that talks about impairments or delays, and it can be more doom and gloom than we intend it to be. But again, it is this way so that we can understand what a family, what a parent, what caregivers are doing to care for their child. So also keeping that in mind, that's something we talk about with assessors, maybe being aware of the tone of the parent interview, maybe leaving time and space to talk about progress and strengths and abilities, towards the end of the parent interview. Every family is a little different, but we try and help assessors understand the range of experiences they might encounter in conducting these interviews and facilitating these applications. So there's a requirement that the assessor meet the child applying. The assessor that we've trained is not doing a formal assessment with the child per se. So it's not like going through an IEP reevaluation process where a child meets with a school psychologist and formal assessments are conducted. The personal care assessor does not need to ask the child to perform his or her ADLs, or they don't need to see them in action doing that. But typically, we require the assessor to actually meet the child. I put this little caveat, this little disclaimer here that COVID changes apply. Going back to last spring, we have requested that assessors attempt to do the child observation via a video conferencing platform like Zoom or Teams or FaceTime. But whenever that's not possible, we ask an assessor to document the attempt, tell us whether it's possible or not and why not, and then we're waiving that requirement right now. So we do think it's in the best interest of the child applying for the assessor to get to have some type of interaction, be able to substantiate and expand upon the information that a parent provides, and that's reflected in the supporting documentation. But due to any risk for exposure to COVID or transmission, we're waiving that requirement when it's not possible during using a video conferencing platform. The supporting and supplemental documentation that we require with our applications, the assessor is responsible for ultimately submitting everything, but this is an area where families might be able to prepare for the application process, go through your records, see what you have on hand, think if there are documents from a child's school team that you might want to request ahead of time. We put this out here thinking that it might help the process go more smoothly. When we receive applications in different installments, and we're waiting on things like supporting documentation, that just delays the process in terms of reaching a decision. And we'll wait and we'll communicate with assessors and families about what we still need. But if it's possible to have those things on hand and ready for the assessor, that helps the process go more quickly in general. Supporting and supplemental documentation, like I referenced earlier, can be many different items. School documents, things from a primary care physician, from a specialty provider. Ideally, we need materials from within the last 3 years. And even better, if the materials describe the child's functioning in the activities of daily living domains, great. But again, because we do look at a child's needs related to learning and socializing and communication, any report that comments on the IADLs as well is probably worth submitting. And then just to be really clear, the first step in requesting a personal care application for your child is to call your regional designated agency. The intake numbers are available on the website maintained by the Department for Disabilities, Aging, and Independent Living, DAIL. That's where that link in the previous slide goes to. There's a list of all the regional designated agencies and their main intake number. And families in any of those regions can call their regional DA and say, I'm requesting a children's personal care assessment for my child. And that'll start the process. So, doing on time here, okay. So when we determine a child is eligible for personal care services, we send out a decision letter to the family that explains the decision, including some details about the level of services authorized, and we provide a list of the general program guidelines. Basically, how can you use these services? When we do this, behind the scenes, we prior authorize a spending limit with Vermont Medicaid in their medical records system based upon the number of hours per week that were determined medically necessary for the child. So the authorization itself includes sufficient funding to pay a personal care attendant, a provider, for the full amount of hours per week at the base Medicaid wage of $13.74 per hour for the entire range of the authorization. And typically we authorize personal care services 6 months at a time. During COVID, one of our other program changes has been to automatically extend kids who are already receiving the service at least 90 days at a time. We started doing this last spring as a preventative measure to avoid anyone lapsing in their coverage with personal care services. And we have authority to do this from the Centers for Medicaid and Medicare. It's temporary authority. So we've been authorizing prorated amounts, so 90-day authorizations automatically for any child already enrolled going back to last spring at the current level of service that they've had. Typically, we authorize in 2 6-month segments that go concurrently so that when a child is first found eligible for personal care, they get a year of service before they are due for a renewal assessment. So when we talk about personal care services in a self-directed model, we mean that self-direction, broadly speaking, means that an individual service recipient, so in this case, a child or an adolescent, or their surrogate, have flexibility and responsibility over key aspects of service delivery within a given program's guidelines. So for children's personal care, this means that an eligible child's parent or primary caregiver becomes the employer of record and is given access to that spending limit of Medicaid funds that I referred to previously, that they can use to hire and pay a personal care attendant to provide one-on-one care to the eligible child. So there are some key players in a self-directed model like we have with children's personal care services. For a parent or a primary caregiver to become an employer of record, that's a relatively, it's a pretty official role that someone has to play. So the state of Vermont maintains a contract with ARIS Solutions. ARIS is a nonprofit fiscal agent / intermediary support organization that provides some key payroll, administrative, and tax-related assistance to individual employers who administer their child's personal care benefits. ARIS provides these services to a host of Medicaid programs across the pediatric and adult systems of care. And ARIS is really a family's first line of support with questions related to funds that have been authorized, how to complete timesheets, remaining funds over an authorization period. ARIS helps families enroll as an employer, as well as hire and enroll their employees that families find and recruit. They conduct background checks for employees that families want to hire. And this is a relatively new requirement that I'll mention in a few more slides. ARIS is also responsible for assisting families to report electronic visit verifications when that's required with personal care. So another key role here is the employer of record, which I'd said previously is typically a child's parent or primary caregiver. It could be a home provider. It could be someone else that the child's guardian has identified, but it's the person who is going to be the most responsible for administering personal care services. So recruiting, hiring, and overseeing personal care attendants, scheduling shifts, reviewing and signing timesheets, making sure funds are used within the spending limit over the course of an authorization period, and completing their part of electronic visit verification responsibilities. An employer has some flexibility with administering services. So we authorize funds that allow families to pay a personal care attendant $13.74 an hour over the course of the whole authorization period in order to get access to the entirety of the hours that have been authorized. Employers have some flexibility to pay up to $15 an hour and potentially use fewer or a few more hours per week than were authorized, so long as that spending and that utilization stays within the funded limit across the authorization period. More details about this flexibility are in the program guidelines as well. And finally here, the role of the employee in this arrangement, otherwise known as the personal care attendant, is the person responsible for providing direct care to the child, completing timesheets in a timely manner, and completing their responsibilities related to electronic visit verification when indicated. So under federal rules, a child's parent or primary caregiver is ineligible from being paid as a personal care attendant. This is a pretty well-established, long-established federal regulation. In Vermont, this extends to step-parents, adoptive or foster parents, or a parent's domestic partner. Now you'll see my COVID changes apply disclaimer here. During COVID, we have permission to allow these groups, these individuals to access personal care services. And I'll talk about that in a few more slides here. Typically, employees must be 18 years old and pass the background screen. Employers can consider hiring somebody 16 years old and up, paying a bit more than $15 an hour. And depending on the nature of what comes back on a background screen, employers can request a variance to allow to be allowed to hire somebody who had something on a background screen that initially prevented them from getting hired. So there is a variance process related to the age of the provider, related to the wage, and potentially waiving some background check findings. So electronic visit verification that I've mentioned here, it's a new federal requirement. It's called EVV. It's a telephone computer-based system that records specific information about services provided to Medicaid members. And it's a federal requirement for all Medicaid personal care services. So children's personal care services in Vermont is in scope, and families and participants are required to use EVV. Again, ARIS is the resource for EVV in terms of how to enroll, what needs to happen, and to provide technical assistance on an ongoing basis. There are links, and there are a whole host of training materials related to EVV linked from ARIS's website that actually go to the Vermont Medicaid website as well. And I think we're going to be doing some Q&As hosted by ARIS about EVV in June and July. And those dates are, and signups are available on the ARIS website as well. EVV is new. It's still being implemented. Bugs are being worked out. It is a federal requirement. There are two exceptions for when children's personal care services participants are not required to use EVV. And these are when services are provided entirely outside of the home setting, or when services are provided by someone who lives with the recipient. So I'm going to keep moving here. We'll come back to this. I'm conscious of our time now, too, Jamie. Like I said, ARIS Solutions is available to provide technical assistance around EVV. And there's a link for you. Okay. So some key changes have been implemented around children's personal care services going back to last March 2020 even. So a variety of Medicaid programs in Vermont requested permission from the federal government to make changes to how programs are run and to some of the guidelines and rules that are typically in place. This was done in order to help families and beneficiaries maintain access to services and supports. It was done to find ways to be flexible about these program guidelines so that people are not prevented to access care while being at greater risk for transmission or contracting COVID. So like I mentioned, with children's personal care, we started extending service authorizations without requiring an actual new application. So that was to prevent a lapse in benefits. That was to prevent the need for coordinating some type of application with an assessor when there are social distancing guidelines in place. And then the most significant change here is around, it looks like this sentence cuts off here. So sorry. Parents and primary caregivers are eligible to access personal care funds and in what we're calling COVID payments. And there's a bunch of information available about the COVID payments. They're still active. They come out of the child's typical personal care allocation. There are some different guidelines. There's some different reporting requirements. There's a guidance document that describes the COVID payments online, linked from the ARIS website, as well as our website on the health department, our page on the health department's site. And then we did make some changes to the application process itself. Like I referenced earlier, we waived the observation requirement whenever it's not doable via a video conferencing platform. We've loosened some of the timelines that are typically in place for assessors to be able to submit things within a given time frame. And all these changes were done in the hopes of maintaining access and lessening barriers to accessing care during the public health emergency. So this is the final slide, some contact information for the program and for ARIS Solutions. I'm happy to go back through any of the materials or go into some questions here. I would also just like to say that, the program staff, we want to be reachable and really accessible to families. So things that I glossed over today, areas of the aspects of the program that I didn't go into a lot of depth on, I'm happy to plan follow-up conversations with families who have the service and have questions, who have feedback, families who don't access the service currently, but want to know more. Again, we aim to be reachable and responsive to families with any questions around this. So thank you again to Jamie and Rachel and Vermont Family Network for hosting. Thank you to the folks who participated and trundled along with me here.
Thank you, Adam. This was extremely informative. We do have just a couple of minutes for questions. So if you do have questions, please feel free to ask directly or put them in the chat. Mindy, do you have one?
Yeah, I have a question. Adam, thanks for being here. And of course, the jets are flying over. I'm outside, but thanks for being here. That was a lot of great information. I took a ton of notes, but I have a question about some working with families that are in the process of trying to get to a diagnosis. Should they really wait to start the PCA process until there's a firm diagnosis, or could it be done like, you kind of know where it's heading, so let's sort of open both doors at the same time?
Sure. I mean, that's like a real 201 level question. That's great. Thank you. I think it depends on some key details. If Vermont Medicaid is active, I mean, that's a pretty clear-cut requirement. So assuming there, Medicaid is in place and there's questions around diagnostically what's happening for a kiddo, our clinicians certainly would want to see the most up-to-date reports that describe, the child's presentation. At some point, even if we found a child eligible and there were some questions about diagnosis still being worked out, for the Medicaid billing does require a diagnosis code as well. So in part, we are obligated to verify that there's a long-term health condition, developmental, behavioral, mental health of a physical nature. It doesn't have to be a specific diagnosis, it has to be long-term, but we do need there to be a diagnosis, both to meet our Medicaid requirements and ultimately for Medicaid claims to be submitted using a code. So if there's truly no other diagnosis that's already in place, maybe even something provisional, maybe like, a global developmental delay, like that would be fair game. That's a diagnosis for children up to a certain age, right? I think while prior to being able to do maybe more formal IQ testing, but that would meet our requirements too. So if there's a provisional diagnosis that kind of hints towards potentially what might be coming, that might still be worth starting the process.
Okay, Thank you. And another quick question. I'm a family support consultant at VFM, and I also worked in the early intervention program for years. And where's the balance of, like I had a caller call in and they had already started the application process. The child had a speech delay, and, in my mind, I was a little bit like, oh, I don't know, and so where's the balance of like, I mean, on the one hand, it's not my role to determine eligibility. And my philosophy is, they can't say yes if you don't ask, kind of thing. But where's that balance of like, we don't want to lead families to lead them to believe that this is a resource that is eligible, that they have access to when maybe they don't.
Sure. I think I could have approached this presentation from so many different angles, and that's certainly a good one to keep in mind, like setting expectations. I think, I guess what comes to mind is that when we train assessors, we want them to feel comfortable, helping a family understand the expectations, really the nature and intent of personal care. So in that case, with a speech delay, if there's not a core ADL deficit as well, that clear need for support around speech, that wouldn't potentially get a child in the door. And yes, we would want an assessor, or we would want someone in your role to feel comfortable saying that, speaking with confidence to the intention of personal care services. At the end of the day, I think, if a family is going to apply, then we're gonna take it all into account, look at the individual circumstances of the child. I didn't mention this in the presentation, but when we issue a decision, any Medicaid decision comes with the right to appeal that decision, right? So if we were to deny personal care benefits, the denial letter would explain that family's right to appeal and what that process looks like. I'm not saying that would change the outcome, but that's just that's recourse that's available to families, as it should be. And we wouldn't dissuade a family from pursuing it. I would want to have an opportunity to help a family understand the intention of the service, how the review is done. And I would want assessors to feel comfortable also, assisting in that education, I think, essentially around the program. So if ultimately, though, I think families are entitled to apply, if they want to explore this option.
Okay, great. Thank you.
Sure.
Adam, I had a quick question for you. It goes back to the eligibility and the ADLs. It's kind of a two-part. Can a child qualify in just one area? So if, take, for example, walking, if there be like a 3-year-old not walking, could that one area qualify them? And I didn't hear you mention safety at all. And is that part of the eligibility requirements or a piece that you look at?
Sure. So there's no minimum threshold with eligibility. So you don't need to qualify in multiple domains to get in the door. If the need for significant extra support in one ADL domain is determined medically necessary, according to all that criteria that I blabbed about earlier, then that might be enough for us to authorize personal care services. Sure. So there's no minimum threshold. Safety factors in when we can tie it to the activities of daily living domains. So the need for general safety and supervision is real. I mean, maybe a huge challenge in a family's life, and maybe just something that concerns them day in, day out. But unless there's a safety need related to one of the ADL domains, we don't have authority to authorize personal care services. So safety in one of the ADL domains could be a child who, a 15-year-old who is independent eating, but due to a muscular issue, you might aspirate and needs someone there to provide supervision for a safety-related issue. A child with a seizure disorder that is not managed, and so that child can typically take a shower by themselves. But if their seizure disorder and seizures are not stabilized, they'd be at the risk for significant injury or worse. That type of scenarios where safety in the context of an ADL domain is something that we would want to dig into, understand, and then potentially authorize service. Yeah. So general safety. Oh, go ahead. Yeah.
Sorry, I was just gonna say, so thinking of maybe a 4-year-old with a diagnosis of autism where there's bolting and concerns of maybe water and safety there and climbing unsafe places, that itself would not be a reason to apply.
You know, I would rarely get into blanket statements about what will and won't apply, but you know, the way you framed that hypothetical, yes, like that, again, that's likely a huge area of need for that kid's family. And if we got that application, we would want to be connecting with the assessor and their agency to see what services might be available to support that family around those needs. We would, you know, discuss the same thing with the family. But unless that 4-year-old also needed significant help within one of the ADL domains, very likely that need for general safety and supervision would not give us cause to authorize personal care services.
Okay, great.
Sure.
Thank
we would
you.
want to, you know, we would look at respite services or perhaps like an autism specific treatment or support, like applied behavioral analysis. But yeah, the way that hypothetical is, like, that probably would not mean we'd authorize personal care.
Great, thank you. Well, I'm not seeing any other questions in the chat, and I want to be respectful of your time, Adam. Thank you very much for the excellent workshop today. For all of our participants, you will see a link in the chat. Please take a few minutes if you could complete that. It's for our grant requirements. And everyone who registered for today's workshop will receive an email with a link to the recording. So please take a few minutes to complete the survey in the email as well if you didn't get a chance to do it today. We do have more interesting workshops coming up, and you can find details about those on the homepage of our website, vermontfamilynetwork.org, along with the links in the previously recorded ones. We have tons of information on our website, and getting connected with us is super easy. You can follow us on Facebook or join our closed Facebook page if you are a parent. The name of the closed Facebook page is Vermont Families of Children with Special Healthcare Needs. You can also sign up for our monthly e-news or check out our YouTube channel. And so thank you again, Adam. This was super, super helpful. I really appreciate your time today. And thank you everyone for coming, and have a great day.
Thank you so much. Take care.